all for joining us today. I'm hoping everyone can hear and see me. We are at the top of the hour, so we're going to go ahead and get started. I'll give a brief overview, and we'll give it a few minutes for everyone to join and get logged in. But we do have a lot to cover, and we have a lot of folks joining us today. So thank you all so very much for being here. And for those who maybe were not able to join, this session will be recorded and shared afterwards. You will also see a Q&A section on your screen, so please feel free to pose any questions you may have at any point in time. I can't promise that we will get to all of them during today's session, but our team will be sure to follow up with you afterwards. So without further ado, I'll introduce our topic at hand, the DL on GLP1s, or the down low. So with last year's breakout success of the GLP-1 drugs as a means of weight loss, there's been an overwhelming appetite for knowledge, no pun intended there, just in terms of coverage options, patient outcomes, safety, and so much more. While there are still many unknowns and ongoing developments surrounding the use of these drugs in weight management, we're very thankful for this opportunity to share with you all what we do know and how we can just offer our support to you and the plans you serve as we all navigate these waters together. So joining me today to tackle this topic and answer the hard stuff are Miss Lisa Gish and Miss Stacy Bain from the TrueScripts team. Lisa is our Director of Product and Market Strategy. She is a registered nurse by background with a Master of Healthcare Administration, and she is also a certified pharmacy benefits specialist. So in other words, I really just like to refer to her as our Swiss Army knife. Stacy is our National Director of Business Development and Innovation, and she is also a PharmD by background. So she just brings a very unique edge to our team in being able to support partners on the business development side and with a clinical perspective. These ladies are just an absolute wealth of knowledge, and I'm so excited for you all to hear from them today. So let's dive into the DL on GLP-1s. Well, first, before we do that, I think it's very important. We here at TrueScripts start every presentation with our mission statement. It's just the foundation of our very being and so important to who we are and why we do what we do. And that mission is very simple. It's to build lasting relationships. And that is done by providing prescription benefit management expertise at a personal and customized level to ensure optimum value at the lowest possible cost. So honest action and open communication is critical for what we do for you all. All right, so without further ado, I just want to kick things off kind of at a high level and set the stage, lay a foundation for today's conversation. And now, Stacy, if you don't mind, I would love for you to do this by giving a brief overview of what GLP-1 medications are and how they work or the benefits they provide for patients with type 2 diabetes and then patients with obesity. So kind of hitting on both sides of that, please.
Sure. Thanks, Allie. Appreciate the opportunity to be here with everyone today, and we will avoid the science lesson and the pharmacology discussion, but wanted to just provide an overview, really, of what the GLP-1s are, how they work, so that we all kind of have the same basis of information. So when we think about the GLP-1s, that actually stands for glucagon-like peptide 1, which is actually a naturally occurring hormone that is found within our systems, right? So this hormone plays a crucial role in controlling blood sugars in our own bodies. And actually, that glucagon-like phrase, right, refers to glucagon, which is a hormone that actually raises blood sugars in our level. The GLP-1s actually do quite the opposite. They help lower blood sugars, and they do that through a couple different means, which we'll all share here. So what happens is when we eat, these GLP-1 hormones are naturally released by our intestines. It's a part of our own natural response to food intake. So through that, then, these GLP-1s also tell our pancreas to release insulin. And that insulin tells our bodies to be able to use that blood sugar and convert it into energy, which each of us, hopefully right before the lunch hour, our blood sugars aren't dropping low and we're not getting in that hangry state. So these blood sugars are crucial to just everyday energy, right? And how we function. Um, the glucagon piece of it is how we actually, the hormone that is out there that actually would raise your blood sugar levels. The GLP-1s actually do the reverse. So they actually are keeping that glucagon production low so that your blood sugar levels don't rise. The GLP-1s also, we know, slow down digestion. So food is going to sit in the stomach longer, makes you feel fuller longer, which is twofold, right? So this has benefits not only from a diabetic perspective, but from a weight loss perspective as well. And then there's some evidence to suggest that these GLP-1 medications also help our own insulin producing cells within our pancreas actually work better, right? So be more efficient in the insulin that they're able to produce. Interestingly enough, this chemical, the GLP-1 hormone, was actually originally founded back in the 70s and 80s. And over time, they saw that there was benefit to those, specifically with type 2 diabetes. So in the early 2000s, they started developing medications that lasted longer than our own internal GLP-1. This hormone is released and is used up by our bodies very quickly. So the studies were actually looked at how could you create a GLP-1 product that actually remained in our systems longer. So in 2005, the FDA created the first GLP-1, which was Byetta, quickly followed by Victoza. And these were specifically used for our type 2 diabetic patients to improve their overall blood sugars. And then now we are where we're at today, right? So the GLP-1 class of medications has kind of exploded. We know that there's benefits for not only our type 2 diabetics, but for those that are looking, from a weight loss perspective, specifically talking about those who, would fall into that obesity category. So there's lots of benefits. That just kind of lays the groundwork of how these medications work, kind of a little bit of a history lesson of where they came from, and we'll dive deeper into more of these in just a minute.
Thanks, Stacy. The very helpful and informative there. So knowing all of that, how do GLP-1 medications compare with other treatment options in terms of efficacy, safety, and patient adherence? Are there any significant risks or side effects associated with the GLP-1s that should be considered?
Yep, great question. I think the when we look at these from the GLP-1s from a diabetic perspective, we know that they work amazingly well for our type 2 diabetics. And they do that through a couple of ways. Obviously, we're lowering their blood sugar levels. But when we think about how we would lower blood sugar levels in just diabetes as general, we would be using insulin type products, which do put people at risk for hypoglycemia. Nice thing with the GLP-1s is that members are not at risk from a hypoglycemia perspective, meaning their blood sugars are not going to drop too low and put them at risk for other things. And an additional side effect or benefit from these medications is we also saw weight loss, expected weight loss, as well as the cardiovascular benefits that come with this. So we know that members that are taking these medications are at reduced risk for heart attacks, strokes, and other cardiovascular disease. So there's a lot of benefits that go along with treating our type 2 diabetics with these type of medications. And on the flip side of that, when we look at what are some of the other agents out there, whether that would be oral metformin or insulin products, those come with their own other, side effects as well as treatment. So these are great products, especially for our type 2 diabetes and being able to control their disease state with really minimal, side effects. I think the one thing to consider when we think about what are some of the potential concerns with these medications, most commonly what we're going to experience would be the gastrointestinal issues. So that could be anywhere from nausea, vomiting, diarrhea, constipation. Typically, these are dose dependent. So the larger the dose, the more likely that you would experience these. If a member were to experience those and we would reduce the dose, typically those are going to go, be diminished or go away over time. Pancreatitis is a concern. So these are things, this is be an inflammation of the pancreas. So that is a potential concern with treating with the GLP-1s. We also know that members or individuals that would be treating with these would want to make sure that they didn't have any sort of family history or past medical history of any thyroid tumors. So these were shown, to produce tumors when they studied these in lab rats. So that would be a warning with these medications as well. And then lastly, we know there are some gallbladder issues that come with it as well. So potential risk for gallstones. So while these are amazing and they really do great things for our diabetic population, they don't come without risks. And I will tell you, this is something that on a daily basis, I see and read articles. There's more and more information coming out about this, more and more potential side effects and benefits to treating with these medications. So it's ever evolving, even as we sit here and have this conversation today.
Absolutely. And now you just touched on this a bit, but are there any other ways that patient demographics or comorbidities can affect the efficacy or safety of these medications?
I think there are some when considerations to utilizing these medications in the right to the right patient population, right? So if we know that a member is at risk for other cardiovascular disease, there would be a case, right, to utilize these medications maybe more first line within their therapy because of the benefits of not only being able to manage their type 2 diabetes well, but also all the benefits that come with it. So reduced cardiovascular events. Sometimes over time we see that not only managing their diabetes, but with some weight loss in that diabetic population, you can see increased blood pressure. So lower blood pressures, improved lipid profiles. So there's so much benefit that can come with treating these. And I think on a case by case basis, we have to look at those other comorbidities and how, what is the right drug for the right person, kind of looking at the whole person, not just necessarily whether it's type 2 diabetes or obesity.
Stacey, thank you for all that. I know everything in that clinical and safety realm is ever evolving. And like you said, we're learning more on, both the good and the bad sides of all of that. And so for everyone on the call, we at TrueScripts will do our best to keep you all in the loop, send out communications information as it becomes available to us. So now moving on to the economic considerations of the GLP-1s. This may be where some of the biggest gaps in information exist currently, especially when it comes to the long-term economic considerations. But it's a very important point of discussion nonetheless. And Lisa, I would love if you could provide some insight as to what information is currently available about the cost-benefit analysis of including GLP-1s in self-insured plans.
Yeah, be happy to, Allie. I've said for a long time, if these drugs were about $200 a month, we probably wouldn't need to have this kind of discussion. But reality is that they range from 800 to 1200 on average a month, and that's just not sustainable. So we have to look at all of the factors surrounding this, make sure it's a good benefit to offer. What are the receivables, right? What do we get in exchange for this investment that is being made by plan sponsors? So on the diabetes side, I think the road is pretty clear. The ability to drive down hemoglobin A1C, which means your blood sugar is controlled on an average over the course of 3 months. That's what that one measurement tells us. That's pretty valuable because when that happens, we're less likely to develop much slower the complications from diabetes. So impacts to our eyesight, impacts to our limbs, and the microvascular changes that can occur that Stacey talked about with heart disease, stroke, other complications. So, that's the gold standard for diabetes is A1C management, long-term blood sugar management, and how we get there is really important. So I think that on the diabetes side, I think there's significant support of the health benefit. Now, does that tie in with the economic benefit? I mean, it all depends, right? So we've had conversations internally and externally about the fact that as an employer, if you have a high turnover, that's tough maybe to see the return on this investment, but nonetheless, on the diabetes side, we will see patients get started on these medicines appropriately, and that cost have to be borne. I think where the biggest controversy exists today, and certainly where the number of questions that we field all the time exist, is on the weight loss side. So, and that really, I think, the economic consideration there is very varied because we also have a lot of side effects. Stacy pointed that out. How long do people take these drugs? Right now the average seems to be about 2 years that patients can stay on them, but there are many, many instances where patients don't stay on there for very long at all. In fact, only a few months, and that is due to the side effect protocol. And also what we see is that they may bounce around from drug to drug because while these drugs may have the same common ingredient, the way that you take them could depend on the side effects you get. For example, there's an oral form of the main drug that's in Ozempic. Well, it's going directly into your GI system. That could have a different side effect profile than when you inject it in your body. So some patients could tolerate one over the other better. We do also have each of these drugs is meant to be started at a low dose and increase over time, and up to a titrated maximum dose that's indicated for the specific condition that it's approved to treat. So, again, as we see patients migrate through that, sometimes they fall off. So, again, when we're thinking about what is that cost impact, what is that return on investment, it has a lot to be considered. So we like to talk about really sitting down with plan sponsors and thinking through if they want to consider offering weight loss coverage, or if they're offering it today and they want to say, should I continue this? We really need to go through a lot of factors with them and really help them understand what their current exposure is. Some of the things I think we're going to talk about later with regard to policy, how do we manage the control of these drugs? And they could be a big impact too.
And I know this is something we likely don't have a ton of information on at the moment, going back to the long-term economic considerations. But do either of you have insight on how the cost of these GLP-1 medications might compare to long-term healthcare costs associated with untreated or inadequately managed diabetes or obesity?
Well, I mean, you take any one of the conditions Stacy talked about, a heart attack, stroke, um, loss of eyesight, mobility issues from obesity, musculoskeletal. I mean, you just take any of those avenues and you walk down that path, and you could say, gosh, there is an opportunity here, right? You could definitely think about that. In fact, we're hearing stories of patients taking the weight loss approved medications on a short-term basis to help them qualify for weight loss surgery. So, there could be a short-term use that has a good endpoint for someone, because we know that the research exists in a more long-term impact on what weight loss surgery can do for those conditions. So, we've seen patients easily come off of other medicines for high blood pressure, for cholesterol. We've seen them manage to turn around other types of issues in their health that they're dealing with. So, I think that, I mean, the cost of a stroke, I'm not sure what that is anymore, but there's many costs. I mean, there's physical recovery costs. There's cost in terms of their earning potential going forward, their loss of, their economic value in the workplace. There's so many things to consider there, but, you put side by side, it still comes down to, what's that analysis look on an individual client basis.
Right. Very fair. So knowing what we do know today, what strategies can readily be employed to help manage the high cost of these drugs? Um, whether that's patient assistance programs, manufacturer discount cards, what strategies can be employed while still ensuring patient access to care?
Yeah, so I think you mentioned some. I mean, anything that exists today in the marketplace to help drive the cost down of these drugs. So again, we also need to talk about how do we ensure appropriate usage of them. But with that in mind, just managing the cost themselves, Making sure that we're utilizing, if there is patient assistance, if there are copay card programs. For some employers, international sourcing might be appropriate. It could be cost plus pharmacy availability. So anything that can happen along those lines. I think what's also true, and we have to consider, these drugs are rebatable. So, from a brand drug standpoint, there are going to be some monies that come back to the plan and help with that overall net cost. But again, rebates don't happen today. They happen 3 or 4 months after the end of the quarter. So it's not money that is reduced at the time of the claim necessarily. So we have to factor all of that in place. I think the one mistake that we can all make is just thinking that we should just go forward and pay for these. We need to think about how we're approving them. We need to think about how we're paying for them. We need to think about who gets access to them.
So once a plan has made the decision, you're covering the GLP-1 drugs, there are still many things to consider for efficiently managing coverage, containing costs, ensuring clinical safety, all of the above. Stacy, I would love if you could kind of give an overview or discuss some of the criteria that should be used in determining eligibility for coverage of the GLP-1s in self-insured plans.
Yeah, I think this is really super important, right? So obviously we have conversations around whether or not to cover these from an obesity perspective. We know these are already being covered on your plans today from a diabetic perspective, but it's great to have some guardrails in place to make sure that these are being used and prescribed appropriately, right? So whether that is from a type 2 diabetic perspective or if that is from an obesity perspective. So I think having strong prior authorization criteria in place, covering these medications for their FDA approved indications only. So from a diabetic perspective, do they actually have a diagnosis of type 2 diabetes, right? Not a pre-diabetic. What is their A1C, and are we capturing those lab results? And over time, what has that looked like? Do we know what their fasting blood, glucose looks like? There's a lot of things from a diabetic perspective we can do to make sure that these are being prescribed appropriately, even for our type 2s. When we look from an obesity perspective, prior authorization perspective as well, looking at BMI, and BMI probably greater than 30 for individuals. And then other considerations within those, right? So have they tried and failed other lower cost therapies? Have they used some oral medications in both classes prior to jumping to these? When we think about it from an obesity perspective, have they gone through any sort of lifestyle modification? Are they doing diet and exercise? And what is the duration? What's the appropriate duration of that? What were the outcomes of managing that specifically with diet and exercise? I think some things to consider here is if you were potentially considering covering these, do you need to have some sort of lifestyle modification program in place to help support this, right? It likely should not just be medication alone. And maybe participation within one of those programs needs to be a requirement to have access to the GLP-1s from a weight loss perspective. So a lot of things to consider, and I think looking at this from, putting some guardrails in place, having programs to support these people on the backside, and then continuing, I think, to reassess, right? So what are the outcomes and what's the prior authorization process? Going through the prior authorization annually for your type 2 diabetics makes sense. That may not be the best solution when we're looking at weight loss. Do those prior authorizations need to occur more consistently throughout the year, quarterly, biannually, to make sure that members haven't plateaued, that we're continuing to see weight loss, and that the members kind of doing their part of it as well, because we know it cannot just be these medications alone for there to be good success from an outcomes perspective. So I think those are a few of the things to consider, but having good guardrails in place, considering step therapy before you get to these medications, and then how are we managing individuals once they're on these, so that we're potentially not covering them for life if there's no added benefit.
Absolutely. And Elisa, is there anything you can add as far as what we're seeing, some of the trends across self-insured employers for, how they are handling the coverage of these medications? I think this group in particular would really like to have some insight to what we're seeing there.
Yeah, absolutely. And we get asked all the time, like, how many of your clients cover these medicines for weight loss? And for us, it's like hovering around 20%. So it's not overwhelming, but I can tell you that the other 80% are asking us questions. So there's just this mindset of, do I need to cover these from a recruitment and retention standpoint? Am I going to be remain in an employer of choice position if I don't cover these drugs? So, the implications, I think, are far reaching, and it's rightly so. I mean, the popularity, we see advertisements on Facebook, TikTok, Instagram. I mean, social media is flooded. We have stars that are, in the public eye, that are promoting the use of these drugs and telling their stories. So, the promise that people see in front of them, whether it's real or not, whether it's the right road for them or not, I mean, it's just valid. It's all right there. So, we have about 20% of our clients that are covering these medications that are approved for weight loss. We have them all looking at how they're covering them. And, one of the benefits that TrueScripts brings to the table, I think, is a pretty strong prior authorization program today, where, we are looking at step therapy before, any approval can happen. We are also looking at their BMI. We're looking at comorbidities. We're not necessarily making, long-term approvals. Once we get everyone past those points, we deny about half of the prior authorization requests because something isn't met in that regard. And that's pretty unique from the standpoint that's lower than our overall prior authorization, but I think it's rightly so because we really do have to be vigilant here. So I think the one most important thing, and Stacy mentioned this, is from a weight loss standpoint, this can't just be a drug benefit. You have to wrap this in with a very well-managed wellness benefit that is looking at other aspects that will ensure success. And that's really what we're after here, success. The goal of taking these medications from a weight loss standpoint is obviously reducing body weight by body mass, but also improving health. And we can't do that with just drugs alone because there are other factors that have to be considered. So that really is where we're seeing the greatest success happen, is where we see those programs exist as well. So, our lane is drug management. We can help provide pointing patients to those programs. We can apply prior auth criteria that says you have to be in a program in order to get coverage of the drug. So, we're in a unique position to be a great partner in that process. And that certainly is what we recommend. It really can't just be drug coverage, or else we're going to do nothing but see increased cost.
Thanks, Lisa. I think that just speaks to the beauty of how nimble and flexible the TrueScripts team can be. So I'm glad you added that in there. And now I would love for both of you to weigh in on this one. And, this can be total opinion, but I think, again, for this audience, it's I'm curious to hear your feedback here. So how would you recommend that these insurance brokers or advisors, how can they advocate for fair and evidence-based coverage policies on these GLP-1 medications?
Well, let me tell a story, just a quick story. And it's a personal story. You guys may have heard me say this before, but a good friend of mine has her pharmacy coverage through work, and they use one of the big three PBMs. So we're not going to name names, but just leave it at that. And inside of the office, she was, they talked about the fact that she needed to probably start taking a drug like Ozempic, and had some questions. They had dialogue. Into the discussion was, yes, that would be the direction. Of course, her nurse practitioner, I think, as I was told the story, knew that prior authorization was very likely. So she said, I will take care of that and get it started. And literally, my friend told me that as she went outside of the exam room, went to the checkout counter, like all doctors' offices have. And before she made it to her car, she had a text message that said she had been approved for this medication. And it seems to me that a prudent process would not be that short. So, I think that when we talk about how do you make sure, you need to ask the questions, exactly what steps are being taken, but also realize this, these are rebated drugs. So in the PBM models where rebate dollars come from manufacturers and they are factored into revenue streams for PBMs, that's a factor that has to be considered. It could mean that we have less intense prior authorization happening, more just checkbox kind of thing happening. If it's too automated, they're probably not getting lab results. They're probably just saying, having things be affirmed. Does your patient have? Yes or no? Is your patient's A1C below this level? Yes or no? And so it all results in a very automated process. So I think that that is probably the low bar, and we all can do a little bit better.
Absolutely.
I think from my perspective, just staying up to date on the clinical information and use cases, right? So understanding the benefits, this is ever evolving. And so, making sure that staying up to date. I think the other thing is really education to stakeholders, right? So from a broker perspective, educating your employer groups, HR, around the things we're talking about today. What are the benefits? What is the cost versus risk? And whether that is like actual cost in dollars, or is that adverse events versus the benefits, right? So all of that benefits versus risk type of discussion. To Lisa's point, this might not be right to cover for every client, every group out there. So educating, understanding where people are coming from, if it's a benefit that makes sense, I think goes a long way in understanding all of these kind of complexities. And costs associated, whether it be dollars or whether it be potential side effects or others, I think is super important into making sure whether or not it's right to cover these or not for groups from a kind of global perspective.
Yeah. And Stacey, to add to that, I mean, because education is so important on all of this, guys, the TrueScripts team is so happy to stand as a resource for you all in providing this education, whether that's through just flyers, client or member facing materials. We're hopping on a webinar like we are today. Here in a couple of weeks, we'll do another one of these that is client facing, but we know how important the education piece of all of this is. Getting everyone to understand the prescription benefits ecosystem will allow them to get the most out of it. And we are more than happy to support you all in whatever capacity we can there. So now before we move away from the policy and coverage criteria, there's a question in the Q&A that I think is very relevant to this. So you guys, the question is, have any utilization management processes for anti-obesity meds affected rebates in your experience? Lisa, can you weigh in on that, please?
Not to my knowledge. Rebates are typically driven by formulary placement. So, I think that good utilization management criteria are anticipated, and they always are on top of formulary. So, formulary is the drug is or isn't in a coverage position, and then you have the eligibility criteria to further define access to it. So we have not run into that situation. I think that the only time we would potentially see that is if we saw a widespread, change in status of these. Certainly at this point in time, again, I shared that we have about 50% denial on these. Now, that doesn't mean they don't come back in a few months and be able to get approved. But again, I think that is, just assumed that we will be having that kind of coverage on top of it. So, and these claims all still get submitted for rebate at this point in time. Rebate eligibility remains intact.
Thank you. Okay, so our next section, we are going to discuss patient outcomes and quality of life, which we've already touched on this several times throughout today's discussion. There's nothing, I don't think, earth-shattering here, but I think there's a lot to consider when it comes to the impact that these medications can have on quality of life, long-term health outcomes. But I think something that we can kind of brainstorm on also is maybe even using these as a retention tool of sorts, increasing workplace productivity, absenteeism. So, kind of again, just kind of an open discussion here on the potential benefits outside of just the direct costs associated with health. But again, back to the workplace productivity, absenteeism. Um, you just have additional thoughts there that, we can share with the brokers and help them use this as a tool when talking with clients?
Sure. I think if this is, if you're putting some guardrails in place and you're doing it very conservatively from that perspective, there are definitely benefits, especially when we think about weight management from just overall health and wellness, right? So, and I think one thing that we maybe have not brought up today is, to me, like reduced pain. So if you have someone who's morbidly obese, aches and pains in your joints, in your back, in those weight bearing joints, I think is something to think about. We typically see better sleep, potentially reduced in sleep apnea. So all of these things I think lead to better employees that show up to work in a better state of mind, are more productive, maybe are absentee less likely than what they may have been before. So I think if we can support these individuals when we think about morbidly obese and the concomitant conditions that come with that, if we can support that member and we can see success in weight loss through these medication processes, we know that there's added benefit to workforce and to their employers, right? But again, we have to consider who is that client or who is that employee group. Is it a trucking industry? What's the turnover rate? Industry perspective that I think you have to consider with this. So while there's a lot of additional benefits if it's done right, and we put some guardrails in place, it may still not be for everyone. They may just not be able to absorb the cost. But those are some additional things from my perspective that we hadn't brought up. But we know there's significant benefit in being able to lose a percentage of your body weight. Just even self-esteem and how you show up to work, right? Let alone the medical benefits that come with it as well.
Absolutely. And it all goes back to, we know there's impact when drugs, and not just these drugs, any drugs, when they're used appropriately. And so I think and that's something that we, manage and look out for here at TrueScripts. Lisa and Stacy both sit on our P&T committee. And this committee meets frequently to discuss all things happening in the crazy world of pharma and making sure that the programs and processes that we put in place are done so appropriately to not just contain costs, but enhance the clinical outcome of these RX treatment plans. Either one of you, as a member of the P&T committee, if you care to add anything there, go for it. If not, we'll move on to the implementation and monitoring, the fun stuff.
I don't have anything there, Allie, but I do want to offer one other thing. A lot of companies do have insurance committees or health and wellness committees, and I would say that some of these concerns are maybe that's the right place to take them. Also, if a client has one of the benefits being an on-site or near-site medical clinic, today that clinic probably is playing a role in your health and wellness strategy. That could be a place where these patients go in order to be able to get access to medications. Maybe that's a criteria for sharing access. And one of the benefits there is making sure, again, that you are having certain things be achieved and watched over. Additionally, from a clinical standpoint, we can approve these drugs all day long. Someone can say, hey, we want them covered. Okay, we'll cover them. We can put criteria in place, but also looking from a patient-specific standpoint, keeping them at the center of this discussion is very important. So if there is a clinic that's available as a benefit, I would highly encourage you to include them in your planning discussions around this.
That is a beautiful lead in to where I was heading with the implementation and monitoring of these drugs and programs. So if you, one or both of you, want to expand on that and discuss some of the best practices that exist for implementing coverage of the GLP-1 medications in a self-insured plan.
Yeah, I'd be happy to. I think.
Oh, sorry, go for it, Lisa.
No, I just say, I mean, I think that necessarily you need to look at how they're covered, which ones you're covering. I have not seen yet there to be a benefit in saying we're only going to cover this drug versus that drug. So, I don't think that's where we're at yet. I think though that the pipeline is huge. The last I saw, there were like over 100, let's just say, drugs that are GLP-1s in the pipeline, in addition there are studies going on for each of these existing drugs for other indications and other benefits that they can provide. So we're seeing great advancements to the point where, we think in the future, maybe not so distant future, we will start to see maybe the standard being somewhat intermittent therapy because the effects last longer in these drugs. So you may not have to take them necessarily even once a week, maybe once a month, maybe once a quarter. It's hard to say, but that is where the research is trending. So I think, keeping all of that in mind when we think about, how do we structure the coverage here, if this is a benefit that you want flipped on, or you already have flipped on, then, you really need to look at how is it being managed today? What are the criteria, the protocols, who all are involved in helping manage this? And I think that's, just prudent, as you realize that this is a benefit that fits in your your health and wellness employee benefit strategy. So, I think that's just so important. We can't stress it enough. Behind that, it really does come down to then the ongoing management. And, what we see in some patient profiles is that there does come to be a point in time where things don't work anymore. There are plateaus, and that's why, as we said, from the prior authorization standpoint, if you're talking about the weight loss side, you probably don't need to just prior authorize this once a year. It may need to be checked on a more frequent basis from a prior auth standpoint to make sure we're still getting the desired outcomes that we've been looking at. I think one other thing, and I'll mention it, and I don't want to go too far into this, but given the cost of these drugs, you know, I could see someone maybe getting approved for this and then maybe selling it. So I don't want to rule that out, that, this could become like a street drug at some point, these drugs, because they are so highly sought after. And again, we see all the marketing on social media for, all the compounded versions. So just, there's so many perspectives we can't not just mention.
There was a member of our BD team who actually had sent a picture not too long ago, as she was driving somewhere on a light post, stapled up there like a missing poster. It says, "We buy Ozempic, Mounjaro," and got an 800 number on there. They were wanting you to call, and they were buying these drugs from apparently anyone who would sell them to them. So you're absolutely right. And I think it's very important that we are continuously monitoring the effectiveness and the outcomes of these drugs. Should they be, the plan chooses to cover them for weight loss purposes, we've got to have some additional parameters in place, or you can easily run wild with that. Stacy, is there anything you can add there that TrueScripts is doing? What are we doing on our end to monitor the effectiveness and the outcomes once plans make the decision to flip that switch?
I think, right, obviously currently, we have our prior authorization processes in place for both, whether it's from a type 2 diabetic perspective or from a weight loss perspective. So continually monitoring this. I will say, back to the P&T committee, this was a talking point at our very last meeting, to see if there are things that we should change or do better, kind of do better or do differently, given the current state of where these medications are headed. So always kind of thinking about these and reassessing those from an internal perspective to make sure that we have good guardrails up, and that, as things change and we learn more information, that we are quick to adapt to whatever those changes might be to help protect our plans and members and those that we're working with from a client perspective. I think, Allie, to your point, just kind of wanted to bring something up about, I guess, kind of safety and efficacy, right? We know these medications can be obtained in a lot of different scenarios, right? Through online sources, through compounded pharmacies. I think people need to do their due diligence on where these medications are being accessed. These medications can be compounded, and making sure that if a member would choose to go that route, that they are working with a pharmacy that is upstanding, because we know that there have been counterfeits that have made it into the marketplace. So there's a lot of concern over, because of the demand, because of the cost, that members are trying to access these medications through alternative means, which may or may not be the most appropriate or safe. So kind of educating people on those as well and the risks. These can be obtained through many different websites online. They're being promoted. So making sure that you're getting it from a reputable source, I think is ultimately very important.
Absolutely. Um, Everyone, we have about 15 minutes left. So if there are questions, we would love for you to drop those in the chat. We'll be more than happy to answer those. Stacy and Lisa, one thing that has been brought up, I think, by our account management team when clients reach out, I think some members or even clients think that when some of these drugs gain FDA approval for weight loss, it means that the plan would automatically cover them. But we know that this is not the case. Now I'd like for you to, if you can elaborate on that a little bit, how we can maybe help combat that frame of mind and, messaging that we can provide surrounding that.
You mean, are you asking like if a drug has more than one indication or the same ingredient has more than one indication?
So some of these are gaining FDA approval for weight loss.
Yeah.
However, that doesn't just automatically mean that there should be plan coverage for that.
Yeah. Yeah. So weight loss is a coverage category. The same would be true for smoking cessation, for example. We don't usually ask about coverage categories for high blood pressure medicines, but some of these other types of benefits are definitely optional. So just because something does get FDA approved, it simply means it has passed that test of FDA safety, effectiveness, the things that go along with that. So FDA approval and benefit coverage are not synonymous. They definitely don't go hand in hand. I think one of the other confusions, though, too, is that we do have drugs where, like Manjaro and Zepbound, same medication has been approved for 2 uses, and from a marketing standpoint, they chose to bring the drug to market with a different name from a weight loss standpoint. Probably a smart marketing move. Begin because the coverage is separated by most plan sponsors. So it's a way for people to think about that in a different frame of mind.
And as far as, because as we just mentioned, there are a lot of ways, it seems more and more by the day, for members to access these drugs without insurance coverage. Obviously, at that point, that is a personal preference on their end and nothing that we can formally do. But is there any advice, any messaging that we can provide and gear clients with? Because even if they're getting the outside of insurance coverage, there's still a clinical aspect to this, and we still care for the safety of all of these members, no matter where they're getting the drugs. So what can we do to just provide some insider education in that realm?
But to me, this is the most scary part, because where these drugs are made, what the ingredients are. So if the drug manufacturer, declares a medicine to be in short supply, it can be compounded. So compounding is considered legal in that instance, and that's where we are today with these drugs. So manufacturing has not been able to keep up with demand. What a beautiful position to be in, I guess, if you're a manufacturer. But on the other hand, like semaglutide, which is the medication that is in Ozempic, the salt version is what appears in a lot of compounded products, and it is not the same as semaglutide. It definitely will have a different side effect profile. It is not what's been approved into making Ozempic. So I think the ability of the average person to be able to scrutinize what product am I taking is tough, because Stacy and I could have the same quest and would have a very tough time getting someone to even field those questions for us, give those answers to us. And I think most commonly they would say, oh yeah, it's okay. It's the same thing you've been taking or that you wanted. So, the safety side of things, what is it being compounded with? Is there anything else being put in there for some other reason that we don't know? And what could that impact be? So, but again, everyone's looking for affordability. So these drugs are they're not marketed cheap anyway. They're still a few $100s. But that just goes to show, I think, the promise that people see behind them. But the safety side of things, and manufacturers, Eli Lilly, Novo Nordisk, they have sued compounding pharmacies because of making products that or in a version that is, falls against the guidelines that are set. And there are parameters here, but you still have to stay within them.
Thanks, Lisa. I see a couple of hands raised. I believe I have the ability to unmute. So you can ask. I'm going to try it with you, Michael. If you want to ask your question.
Yeah, Allie, Michael has his
Can you hear
question.
me?
Yes.
Oh, there you go. There he is.
Oh, okay. Because of the possibility of the severe side effects, is it not recommended that there be a protocol for regular lab work to monitor more closely if we're having issues with the pancreas? And if so, are you seeing such testing occurring today?
Stacy, you want this or you want me to take it?
I think that's a a great question. And realistically, based on some of the potential side effects, doctors really should be monitoring this, especially if you would expect, or based on past medical history with that individual, that they may be at more risk for some of these side effects. That is something from a PBM perspective, we obviously don't have a lot of insight to, but from good medical practice, I would hope that physicians who are prescribing these medications are managing these patients appropriately and monitoring for these types of side effects. Yes, sir.
But that's a great question, and all very, very good things to consider. There's so much to look at when you're looking at these
And
drugs.
if I could just add one more follow-up, because you're seeing the commercials where you can get these directly with a doctor's script or online or whatnot, then you are in a point where you're probably not going to be looking for lab works to monitor this type of condition. So those individuals are probably more at risk, no?
I wouldn't disagree. Obviously, anytime when you go that kind of direct route, there is a lot less support and a lot less oversight into the disease management. They're typically kind of focused in their one aspect or area, which is potentially writing these from a weight loss perspective. So they may not even have access into the larger grand scale of your medical chart and knowing whether or not these medications are appropriate or might interact with other medications that you're taking. From a pharmacist perspective as well, when we think about these one-offs through, internet sites or directly to the manufacturer, I think the concern is again that they don't always have insight into the patient's medication history or current med list. So there are opportunities to miss drug interactions or other things that could be caught if it's kind of being filled in like a traditional setting, I would say. So the pharmacist in me cringes a little bit because when we have this opportunity to get medications in multiple locations, it impacts our ability as a pharmacist to catch those potential drug interactions or other considerations because we just don't know that they've had it filled or that it's sitting out there, right? So definitely a concern and something that needs to be kind of considered when a member would choose to potentially go that way. It goes back to education around making sure that they're accessing it in an appropriate manner and maybe a consideration to providing it on the plan so that you have insight to it, right? Potentially.
Right, exactly. Okay, thank you for the confirmation.
Great question.
Let's see. I believe Hal has his hand up. I'm going to. Hal, are you able to use your mic now? I believe it's enabled. You're not? You should be able to use your mic, Hal, but I'm not able to hear you. If you want to type your question into the Q&A, though, we can get it that way. Same for everyone else. If there are any other questions,
There are a few more popping up, Allie, I can get
yeah,
into.
well, I'm trying to, I'm hitting enable mic.
Brent, are you able to speak?
I think I'm on. Am I correct?
There, yeah.
Yeah.
We gotcha.
All right. First of all, your chat box is turned off so people can't type in it somehow, some way, if they just wanted to type a question. But my question is, do you all have any idea what the difference in the cost of the international versus domestic prescription and also the compounding version that is being put out everywhere?
Yeah, I can take this. So that we've seen international probably be about 60% of what the cost is to the plan typically, maybe a little bit less for some formulations in a couple providers, but I'd say 50 to 60 is roughly where we're seeing that sit. On the compounding side, I mean, it's just across the board. Again, there's no regulation. Where I don't believe that we would be paying for any compounded versions currently, so we haven't had claims necessarily to explore that. But typically on the compound side, you want to pay for the active ingredients, and because there's no regulation, it's kind of a wild west of price setting. So what only thing I have to go from is what I see on social media, and that still is probably between a $200 and $500 range on a monthly basis that I've seen.
And would that 60% on the international, would that include the rebate that's going back to the health plan?
So on the international side, there's no rebates.
Right.
It's
I'm saying is
almost
it
outside of the plan.
60% after the rebates gone back to the employer? Is it
60%, yeah, I understand. It's before rebates. So 60% of what a claim, like an adjudicated claim cost, would be pre-rebate.
Okay, so it could be realistically 80% or so, depending on what that rebate is.
Well, I think it would be, if it's 60%, let's just say 60% of if we have $1,000 drug and it would be 600 through international, the $1,000 drug might be 700 as after rebate, let's just say. So
Okay.
that compares to the 600 on the international side.
Yep, thank you. I know that I hear everybody around our area they're using compounding like crazy. So I'm assuming that that's what's going on.
That's most likely.
Mhm. I think the other issue, or just something to bring up, is just accessibility to this, right? So, the manufacturers are having an incredibly tough time keeping up with the demand. And because of that, there are times where it may or may not be accessible through multiple channels, whether it's domestically or even through the international channel as well. So because of the demand, we do see that there are sometimes supply chain issues in actually accessing the medication, which I think when we look at that from a weight loss perspective is not huge. But when we're talking about our type 2 diabetics that need that, to sustain life, we'll say, it's a much bigger deal. So accessing that, for those people that truly need it, versus weight loss is a consideration as well, something to just think about.
Thank you guys. I know we're almost at time, but Hal's question, he was able to get in the chat. It was, how is the line determined as care for type 2 diabetes or pre-diabetes versus weight loss that is not covered?
So that's really based upon the indication in the drug. So, Ozempic, for example, is a medication that's only approved to treat diabetes. So, if someone is approving it from a weight loss standpoint, it's an off-label approval. It's not something that TrueScripts does. And, one of the considerations with off-label use of drugs, and there's some drugs where off-label is kind of a gray line. I think this one's pretty black and white. You may, get into situations where you maybe run afoul with stop loss at that point if you have too much off-label approval happening. But, you have to look at what the drugs are approved for. We can provide a list of that for anyone who wants. every GLP that's in the market and what it's approved for. So on the flip side of Ozempic is Wegovy. So it has a higher dosage than Ozempic. It's Ozempic at a higher dosage, basically, and that's what makes it approved for weight loss. So same medication, different name, different dosage. Someone who takes that high level from a diabetes standpoint probably isn't going to happen. I mean, diabetes is typically capped out at a certain dosage level, and the same would be true again for like Mounjaro and Zepbound, same dosage. Again, that gets a little bit trickier a bit. The same dosages are approved for both of those drugs, just different name. But we can, again, provide you with a list if you'd like that kind of sorts that out for everybody.
Thank you, Lisa. Guys, great questions. Lisa and Stacy, excellent insight. Thank you guys so much. For everyone on the call, we will have a recording of this. Like I mentioned, if there's any questions along the way, please reach out to us. If even if we don't have the answers, we will help find them, or we will at least give our free opinion. But really, we are more than happy to be a resource to you all in any way that we can. If you don't have a TrueScripts contact, you can just email us at partnerwithus@truescripts.com. That's just a general email bank that will get you where you need to be. If not, reach out to your individual BD or whoever on the team that you're connected with. We are all one well-oiled machine and happy to help in any way that we can. So please use us and abuse us. Thank you guys all so very much for tuning in, and we hope to talk with you all soon.
Thank you. Take care.